All right, so this case is going to, this is one of the first cases I actually encountered a couple years ago when we started rolling out PGx testing for some of our independent living facility patients. And so we kind of accidentally stumbled upon, while we were focusing on polypharmacy and deprescribing, and our prescribers were very interested in layering in PGx, that it actually integrated with more of the deprescribing aspect than we initially anticipated, and was not the original intent of getting the panel. So our objectives for the didactic portion is for all of us to be able to define what polypharmacy is and its clinical implications. So why this is something that we in the geriatrics community are so militant about and excited about deprescribing, and how that differs from discontinuation, and especially deprescribing as a solution to polypharmacy in the context of clinical information like phenotypes and PGx panels. So the whole reason that polypharmacy is a concern kind of starts with the idea that our bodies change as we age. So in the medical community, we've always kind of been fairly good at recognizing that children physiologically are different than adults and should be treated differently, especially in the context of medications. And then kind of forgot that after 18, your body doesn't just suddenly stop changing, which now in my mid-30s, I can definitely attest to the fact that that is true. And so really we should be treating our older adults as differently in terms of treatment options as we would our pediatric patients, and kind of on the other end of the spectrum. And so with aging, there is, this your organ and body composition changes. So this can affect pharmacokinetics and pharmacodynamics from a function of organ systems starting to slow down a little bit. And this affects every organ system, and just maybe less elasticity and arteries. And there is a whole host of geriatric syndromes that we talk about that come from this, that you may see just naturally occurring as a part of aging. You see less body water and less muscle mass, and more a higher percentage of body fat. And so that changes our distribution. And then, of course, elimination and metabolism of medications can change with that change in organ function. There's also pharmacodynamic changes that happen. So with change in sensitivity to adverse effects, and a lot of that comes from pharmacokinetic changes, but there's also an epigenetic layer that happens as we age, which is kind of more of an emerging field of how that affects pharmacodynamics and pharmacokinetics of medications. And all of this leads to, of course, a higher percentage of adverse effects, which is where this field of geriatric pharmacotherapy kind of came from. And then as you delve deeper into that, you also start to kind of realize that there are also a much higher rate of treatment failures. And so as we age, for example, antidepressants become less effective. And there are many medications for which that's true. And there are many aspects that go into that. And some of that also then becomes a question of life expectancy and expected time to benefit. And do we have a mismatch there, especially as we're getting on into the terminal stages of chronic diseases? Layering in on top of this, of our physiologic changes of aging, you add the complexity of multimorbidity and how your disease states interact. You add in all of the medications that are used to treat those comorbidities, and how we tend to add on, and then never come back and look at something we may have been on for 20 years. And so now that, over that dose 20 years ago may have been great for that person, and that's never actually reevaluated. So you have your drug-drug interactions, your drug-disease interactions, your disease-disease interactions, on top of all these physiologic changes of aging, which happen at different rates for different people. And so while kind of the goal of PGx testing is to decrease our adverse effects and improve our treatment failures, there is a lot of low-hanging fruit for this, especially in the geriatric population, and where there's also an emerging field of research for how do those aging changes, and do they have an effect on phenotype? And is there at some point a possible phenoconversion, and how would you recognize that in a prospective manner? So polypharmacy is defined in literature there are several studies that looked at this, and they tended to have a cutoff. Some of them had a cutoff of 5 or more scheduled prescription medications, so not your PRNs unless you're using them around the clock. Some of them used 7. Between those 2 cutoffs, there were similar outcomes, and so this was very common in older adults. Some studies actually show even higher than 50%, more like 80% of older adults, but the majority of the studies showed somewhere between 40 and 50% of older adults are experiencing polypharmacy. Almost 100% of the patients that I see can definitely qualify as polypharmacy. And the poor outcomes that have been associated with this and kind of led to this contemporary practice and study of deprescribing is we already know that there's a greater sensitivity to adverse effects, which then all of those interactions play a part in. There's an accumulation over years. So as your body ages and your AUC then starts to increase slowly for these medications, you start to slowly accumulate adverse effects that weren't there 10 or 20 or 30 years ago, that then typically just get kind of blamed on the aging process. And, you're tired because you are getting old. It's all part of aging. And you're having this effect because it's all part of aging. It's a geriatric syndrome. And then come to find out something happens where they progress to a palliative focus, and we take away a lot of medications, and there's this sudden rebound, and all of these things go away because your sertraline that you were on, now that your renal function has started to decline, that side effects like fatigue and nausea and some of the other things that you didn't have when you were started on it in your 50s, now are starting to show up in your 80s. And no one ever really looked at that because we tend to look at new medications to evaluate side effects, and not one that you've been on at the same dose for 20 or 30 years. So this also then, because of all of these interactions, leads to a lot of loss of independence and, ability to perform activities of daily living, ability even to be mobile independently. And of course, we know that the more medications you have, the harder it is to be adherent. About 1/5 of our rehospitalizations happen because of adverse effects of medications, and that is across all populations. So of course, a larger proportion, and if you narrow that down to older adults. And then this kind of big one that I guess I kind of hid here in the middle is the biggest one is an overall independent increased risk of mortality. So people on polypharmacy, independent of other risk factors, so terminal diseases, what have you, independent of healthy, less healthy, very poor health, we do see a shorter life expectancy with people that are experiencing polypharmacy. And then deprescribing came about as a way to combat this. And so it's defined as and differentiated from discontinuation as more of a supervised long-term process, not a one and done, and focusing on medications that may be causing harm or may no longer be of benefit. So it doesn't have to be one of those Beers criteria medications that we want to take away in all older adults, but looking also at, are you really getting benefit from this anymore, especially if you are over that threshold for polypharmacy, and maybe this isn't hurting you, but we need to take something away. And so is this something that the benefit no longer outweighs even a small risk that's there? And so this doesn't always have to end in discontinuing a medication. Gradual dose reductions to kind of find where that new minimum effective dose is, and eliminating a lot of those side effects and risks is also considered a successful endeavor in deprescribing. So this is done very slowly, monitored very closely to look for signs of withdrawal, of worsening conditions, and that we need to maybe bump back up slightly in our dose, or maybe abandon ship on the deprescribing altogether, kind of preserve quality of life, not just length of life. And there are a lot of tools to support this. So these are some of the most common ones we use in the geriatrics world. So there's the Beers criteria, which we're all waiting with bated breath for the final 2023 update that's going to be released soon this year. There's articles written by the same panel of experts for if you're on a Beers criteria medication, what are some alternatives that may be safer? There are websites where you can go in and put your medications in, check whether or not your patient is a frail older adult, and they'll put in recommendations for which ones would you target first. Here's some recommended taper and follow-up and monitoring regimens for you. So it kind of takes, if you don't have a pharmacist in your clinic that is kind of a nerd about deprescribing, then this gives all providers a little more independence and support. The Canadian Deprescribing Network has created some evidence-based algorithms for some of the more common things that we deprescribe, like PPIs. And they also have a really lot of great patient-facing educational tools for some of those harder to deprescribe, maybe more likely to have psychological dependent things, high-risk medications like benzodiazepines, and how do we, educational resources for how do we treat these conditions without medications, since oftentimes that is more effective than medications once you get into those older adults or you have higher rates of treatment failures. Some of you may be familiar with the Choosing Wisely criteria. So that's an ABIM initiative that has helped kind of different specialty organizations come up with their top 5 or 10 things that within their specialty patients and providers should question. So things that are frequently done, maybe not in, the best standard of care. And kind of the new question is, how does pharmacogenetic data play into this? And the way that this has really started to play in for us is more in helping overcome that clinical inertia where, well, nothing bad is happening now. So at least not that we can for sure pinpoint. So why rock the boat? And, in starting to trying to convince providers or patients or families, a lot of times patients are more open to this in my experience sometimes than their providers are, anticipating some pushback. And there's some interesting data out there now too about what are more successful ways to initiate a deprescribing conversation. And so where PGx panels have really come in helpful for us is not so much at the way our providers order them is not so much at the, we are initiating therapy, what is the best thing to initiate on, but more at a point of either we're having trouble dialing this in, let's cut out the guesswork, or we are trying to overcome that clinical inertia. And so you might not be having problems now, but based on your phenotype, you are a poor metabolizer of this medication. And while you're not currently having adverse effects, that might, we see this thing where sometimes people can stay on this well into their 90s and they don't develop new adverse effects. Other people, because of how they age or maybe some other factors, will eventually develop adverse effects. And just like we try to cut out the guesswork when we're initiating or adjusting therapy, can we use phenotypes to cut out the guesswork of you're already a poor metabolizer? So as you age, you may be more likely to start experiencing adverse effects of this, even though you're not today. And can that help support a deprescribing trial with this medication? There have been a couple trials done with pharmacogenetic testing in older adults with polypharmacy, and they have actually shown positive outcomes in reduction in readmission rates, emergency department visits, and cost savings. And so these were done in a pretty heterogeneous German populations, actually. So we haven't truly translated this much into our US population. And most of the genes that they tested were 2C19, 3A4 and 5, 2D6, BKORC1. So some of those ones that are affect more of our top 200 type of medications. We're starting to get some data that of testing, not just because you're that testing just because you're an older adult and you have polypharmacy may be reasonable and justifiable. So, and then on the flip side of that, our mantra in geriatrics is start low and go slow. But what if you are an ultra rapid metabolizer? Maybe we should not start low for something that we need to get up and running more quickly. What if small doses of a medication are causing disproportionate adverse effects? Can we get a PGx panel to help us really hone in on that is actually what we, kind of add credence to that theory that that's what we're seeing with that medication. So one place that we have seen this very frequently with patients is kind of the evolution in the last 5 to 7 years of how we do primary cardiovascular prevention. So you may have seen this in practice, or it's been in the news a lot with aspirin, that we finally, when I was a resident, we didn't have these large primary literature clinical trials telling us that the risks were no longer worth the benefits for primary prevention for things like aspirin. And so it was a little bit of a harder sell. Now we have those, they're starting to get into the guidelines. And what that looks like for statins is in their current cholesterol and primary prevention guidelines, that there is a questionable benefit over 75 years old. So most of these guideline recommendations are based on studies with people less than 75. So we're very confident in those. We have less of a strength, less evidence for that in people over 75. And then what has increased the strength of that recommendation is some large clinical trials in older adults specifically that showed that, over 75, especially for primary prevention and without risk enhancers like diabetes, there was similar rates of cardiovascular events in patients on statins and not on statins, regardless of their baseline LDL. And so this is an easy sell with aspirin, where we say they bleed more and they have no benefit. Let's take them off. And in statins, both because of this and because there is a consensus level recommendation in the guidelines that even if you wouldn't necessarily start them on it today, if they're on it and they're not having problems, it's reasonable to continue it, which is true for a lot of patients, especially the CPIC guidelines talk about this as well with the SCLO 1B1 updated guidelines for statin use. Even if you are high risk for adverse events, if you're on a statin and you're not having issues, then it's reasonable to continue it, right? And then in my world, when we add in a layer of polypharmacy and we're looking for things to try and take away, our risk benefit ratio for that tends to be a little bit more on the risk side, not because we're scared of statins, but because we're scared of polypharmacy. And there's not a ton of data to be able to pinpoint where every aspect of that risk comes from. And so if we can take them away, we try to. And so that leads us, and then if we get PGx data, then, as we see in our case, sometimes we can try and leverage that to maybe you are fine right now, but for having likely no benefit today, are we okay with grabbing onto, continuing on this and perhaps having a risk of developing side effects one day as you get older and your meat and everything starts to slow down. And so with that, there are references in here if you'd like to go back, and I will stop.